Now, let me delve into the extent of surgery which is ideal for gastric cancer. I will be talking about this particular scenario in terms of extent of primary resection, extent of lymphadenectomy, and usage of minimally invasive techniques in treating the gastric cancers with surgery. Quite some data is there as to which patient should go for surgery and which patient should go for neoadjuvant therapy. But once you have chosen to go for surgical procedure, once you have decided that the patient is having a resectable disease, and once you have chosen surgery, the extent of gastric resection depends on the tumor size, the location, the depth of invasion, and histomorphological type. Now, patients who have got extensive local adhesions and local invasion, we would really not go ahead with surgical procedure because it increases the morbidity and mortality of the surgical procedure. The aim is to achieve an R0 resection. The standard definition of R0 being no demonstrable residual tumor, either microscopically or macroscopically. And in a curative setting, there is absolutely no place for an R+ resection. So the surgeon should plan an R0 resection much before he actually attempts the surgical procedure. So he has to take the advantage of modern investigative modalities, modern imaging modalities before he actually delves into the resection itself. And we as a routine in most of the centers have adopted to diagnostic laparoscopy before we go ahead with a definitive resection, because as we said, in India we do not really notice it around 1/3 unresectability, but we do have around 10% unresectability because of peritoneal metastatic disease or ascites, which is positive for malignancy. As you can see from the MS cases database, an R0 resection has much better overall result compared to any R+ resection, whether microscopic or macroscopic. No amount of adjuvant therapy can really take over the responsibility of curing the patient in here. R0 resection is what we should be aiming at and should be able to achieve that one. Now, how do you define an oncologically sound resection? Now, the type of resection that we do may vary from location of the tumor and the size of the tumor. But what we are trying to achieve is at least a 5 cm margin, both distally and proximally. Now, the 5 cm is supposed to be adequate in the intestinal type, which is the commonest type of malignancy in the stomach, and in the diffuse type, which is a little more aggressive and which has got a higher incidence of mucosal spread and lymphatic spread along the stomach wall itself. The minimum accepted and which is proposed is around 8 centimeters. But typically, we aim at around 5 to 6 centimeters margin for all the malignancies, because most of the times we are not very sure whether it's an intestinal type or a diffuse type based on the morphological appearance alone.